Okay, so I'm really excited. I have Dr. Joseph Diaz with me, Joe, as we call him. So he and I work together at Medico, and I mentioned earlier in my talk this morning that I am so lucky to work with physicians that support my dreams and support my organizations. So we're gonna have a little Q&A and talk about what it's like having a biologics coordinator and having that support staff. All right, so I'm gonna let Dr. Diaz do his intro. You guys can hear his backstory, and then we'll chat a little. How's that?
All right. Well, congratulations, first of all. This is a totally new experience for me from coming to a meeting like this. I can tell you that I'm a practicing allergist. I've been practicing for about 35 years and do a lot of biologic work in our office. I can go into a lot more detail, but that's pretty much what I do. I'd like to give a little disclaimer, especially for some of the pharmaceutical people out there, and you know who you are. And one thing, I asked 3 of our staff to come, and I came to make sure that they attended the sessions. And my only disclaimer is after sitting in this audience for a day and watching all the presenters, I have to say that although I thought I knew a lot about prescribing and using biologics in our clinic, I have to say, like, what was his name?
Matthew Zachary?
Like Matthew Zachary kept saying, I don't know shit about this stuff. Just, that's my disclaimer.
I think that's great, and that humility in that, in talking about it. So at Medico, I work a lot with the biologics coordinators, and I also work in between the physicians. And I always say I'm very lucky that I get to talk about what I need to see in your notes and what you need to do to support your coordinators. So I'm thankful to be in that spot, and I love to hear you say that you're learning or, don't know all of these things. We'll regroup on that next week. But having a biologics coordinator in your practice, was Liz always your coordinator, or did she evolve into that role? Because it's such a valuable position. Was that a change in your office, or did you already have that in place from day one?
That's a good question. Obviously, the position for us in our office has evolved over time, and I do need to call out Liz and the rest of our team, Mari and Sandra. I think this position has evolved over time, and it just kind of rolled into Liz with her past experience as she was eager to advance and to learn more. And biologics in our practice is a huge part of our practice. In fact, when we look at the way we run the operation, it's as important as our entire allergy practice. In Texas, where we all are, obviously, by the way, I went to medical school down the street here. In Texas, a lot of the Medicaid, for example, at one point in time mandated the buy and bill model. And so a lot of my friends and colleagues would not do buy and bill, and so they would send us their patients. So our biologic program blew up into a relatively large program, and it became unmanageable for quite some time. And then over the last few years, and clearly over the last year or two, we have a team in place now that it seems like we've been working together for a while, but our team in place has kind of evolved into, I'm very proud of a very successful team, and I really, I'm sure you all, I'd be interested to know in the audience, everyone here that's obviously responsible for all the work behind the scenes, can you raise your hand if your prescribers are engaged in the process, really engaged in the process, and would even understand half the stuff that was talked about today? Raise your hand. There's 1, 2.
Why isn't your table raising their hand?
Hey, are there?
Just had to check, sorry guys.
and
so, not a lot.
Yeah, it's not a lot, but I guess to answer your question is that it's evolved into a team that I am very engaged with, and even with what little I know really after this conference, we're constantly in communication. And I was told early on that for anything to really work in your clinic, that the person kind of in charge has to be on board. All the biologics prescribers that I hang out with and talk to, really most of us do not know a lot of what it takes to get that prior authorization. All I hear, for a while in the past, I would want to know if we were denied and if we were losing money. And then I would, I would go ballistic, and I didn't realize all the process that occurs all the way from prescribing and ordering, which is really the easy part. It really is. And all the process that occurs to the time that you actually collect payment after the administration.
So you're familiar with the prior auth process when it doesn't go well. So how do you feel, and this is kind of a general question, about peer-to-peer? So auth gets denied, right? Then it moves to that peer-to-peer process. And you don't always get to speak to an allergist. That's usually a special request. How challenging is that when you're trying to, advocate and fight for your patients?
Yeah, well, obviously it's very challenging. In Texas, at least, if we have first of all, I like doing peer-to-peers because I can pretty much roll over them pretty easy, right? Because often they're not allergists or pulmonologists in the asthma space. I never turned down a peer-to-peer, right? Never turned down a peer-to-peer. I have my cardiologist. I had to have a procedure done, and my insurance denied it. And my cardiologist, a high school friend of mine, I asked to do a peer-to-peer, and he said, we don't do peer-to-peers. And so I had to pay cash for my procedure out of that. But I guess to answer the question, I'm not really pleased with that. But I got to say, if those of y'all are keeping track in Texas, House Bill 3459 just passed, going to be implemented in January, where they're now also stating that a specialist in the field of the denial of the prior authorization is who you have the opportunity to do the peer-to-peer with. So that's a big deal.
That's a huge deal. So I think that's one of the struggles that just in working with physicians they talk about is that, I got an OB on the phone, but I'm trying to get a respiratory biologic approved. And so yes, you're physicians, but it's hard to communicate all of those different values and policy points back. So having known you for so long and know what you do, you're really into policy. So bringing up what's going on with Texas and the prior authorization, what about on the payer side? How much of it, I know this wasn't in our questions we talked about, but now I want to. So right now, medical necessity letters, you write for your patients, things like that. You're also writing to an insurance company, fighting for policy reform, policy change in order to benefit your patients. And I know from speaking with you, you've talked with your staff, really evaluated the challenges they're facing to incorporate that. Can you elaborate a little bit on that and what that looks like, not all the way through the process, but the emotional, drive behind it?
So the other thing I want to say about, just real quick,
sure.
House Bill 3459 in Texas, again, just passed, states that as of January, really when it's going to be implemented, that if the prescriber has a history of having at least 90% of their prior authorizations approved in the previous 6 months, then that payer has to give them a gold card where they do not have to get prior authorizations moving forward for up to a year. And that's huge because it also includes biologics and all medications. So that's huge. There's all kinds of caveats in that, but that's one thing. So yeah, I don't know. I like controversy, and I like to go to battle with payers because I think payers really hurt our patients and hurt our practice in many ways. And so, yes, I advocate all the time. I have a strong letter I'm just writing to a payer right now who is starting to mandate that we make our patients get their self-inject their biologics at home, and they're starting to mandate that. You all probably know who I'm talking about. And so I've not only written a strong letter, I've asked manufacturers to help with that. I've asked the Texas Allergy Society, they're on board. I asked the AMA, they're on board. I asked the Texas Medical Association, they're on board. It takes a lot of work. And I realized over Labor Day, I wasted 3 days pretty much on this issue where I could have been doing other things, like spending time with my wife, I guess, but I didn't.
Choices, we all make choices, okay? And letters go a long way. Now, in my experience and where I come from, I would write the letters, I'd pass to my physician, they'd say, yes, no, this looks good. So I admire that you actually wrote the letter, though 3 days, that's a heck of a weekend there. So kind of going back to clinical practice, several points I've made throughout this whole conference is in my role as a biologics coordinator, I worked very hard to allow my physician to assess the patient, make a clinical decision, and I would take it from there. When you're making a clinical choice and you're picking a medication for your patient, do the ancillary things ever come into play? Do you ever think about copay card programs or the type of insurance they have. I know the reps all speak to us, but as a prescriber, it's a little bit different for you. Does anything ever come to mind, or is it, that's kind of an ambiguous question, I know.
You know, throughout, as I've watched the landscape change so much in healthcare, that there was a time where I had to know, you know, was one inhaler covered by one insurance? I mean, in the very beginning of all this, it was starting to change, and I kind of gave up that fight. And again, I rely on our team. I think there's no way that I could address all those issues. And I don't try to explain to the patient that I just prescribed the copay assistance opportunities. We do what's called, we try to do what's called patient or shared decision making, but usually I decide, or I decide which drug I'm going to recommend, and then really I have to say, I right then and there, once I give the order, someone from our biologics team comes straight over and helps in consenting the patient, has them sign the forms, talk, you know, does everything right then and there. And then I only hear about it on the back end if there is a problem, or they need a letter, or they need something else in the clinical notes. And I'm more than willing to write letters and do the clinical notes. And then I keep hearing along the way. We just kind of recently implemented, I don't know if you all are aware, but compliance is a big problem with biologic therapies, right? Mm-hmm. Right?
Patient adherence and compliance.
Yeah.
Yep.
So Dr. Singh in the audience did a study on a biologic, a 10-year study, and showed that we were losing 20% a year. 20% a year because of compliance and adherence. And so we've implemented policies now to where we have protocols in place, and then finally, if they can't get it done, it escalates to my desk, and then I'll talk with one of the providers who wrote the prescription, or I'll call my patient. And usually I'm the last one there at 7 o'clock at night, and I'm calling the patient at 7 o'clock at night and say, look, what's the deal? And it's something funny that when the provider calls, they seem to re-engage and start coming back in. I don't think it's fair for you guys, but it is what happens.
It is, but it's great that a provider would do that. So we, as a biologics coordinator, it's true. There's, you know, when I teach buy and bill, I got an email yesterday from someone. Hey, I've called the patient 3 times and they haven't come in yet. I need to start them on this medication. What do I do? And it's like, well, you could send a letter. Snail mail is not exactly fast right now. But the value of the provider calling and saying, hey, what's going on, I think really raises the bar. And I wish every advocate could have that experience. When you do speak to the patients, do they ever give you a reason why? Do they ever ask questions? What usually happens in that situation?
They usually blame it on my team. Yeah, they give lots of reasons. Okay. You know, we even track patients that are home administration. You know, there's a product out there that's only available for home administration. And we even track those, and it turns out that there's a lot of miscommunication. You know, this whole issue of equity, I think, is important also when you start to force patients to self-administer at home and maneuver through this SP process and maneuver through the shipment and delivery and storage of the medications. And so they give lots of reasons. A lot of times it's not even their fault. They just don't know.
Sure.
A lot of times it's, in this case, in the home administration, it's miscommunication or communication with the SP. Mm-hmm. And so I personally am an advocate of in-office administration. Just want to throw that out there. My patients, especially my underrepresented minority type, my underrepresented patients, I mean, they're having enough difficulties living with all the social determinants of health that affects them. And I'm much more, I don't want them to have to deal with an SP, home delivery, be there when it's there. San Antonio's pretty hot, and I definitely don't want them to store it. And I love the new term now. It's not lost to follow-up, it's lost to fridge, right? A lot of issues and concerns with non-compliance and adherence in the home administration. So we think bringing that in and being able, when a patient doesn't show up, they let me know. We have a process, but eventually we know that the patient's not getting their injection. And we think it's a process that helps us improve compliance. And some patients we stop. I mean, we stop. There's good reasons, and we have to try alternative therapies. There's good reasons, but at least we know who is stopping and who is on.
Sure, absolutely. And that's hard with the home administration. Luckily, in the allergy space, we tend to see those patients, especially on asthma biologics, we tend to see them more often than once a year with other disease states. So at least there's that rapport, but you're right, it's tough. Now, I do say the ice packs that come in those home deliveries or even to the office, those ice packs are great. So also coming from the buy and bill side and not going the SP route, there's cutting out kind of a step in that process, and that's scheduling and all that. But still, some patients have to go through specialty pharmacy. Is there ever a time that you have to get involved with that process? Or I'm sure your office has that handled, but what does that look like? Do you see the frustrations? Do you hear complaints from patients about delayed shipments or anything like that?
So I have a patient, little girl, you all know I'm talking about TP. Her first name's Tony. Lots of issues with compliance. Lots of issues with compliance in the family. They're underserved. They struggle, and they were on a home administration of a product for her severe asthma, and lost a follow-up. We tried to call. They wouldn't come in for the office, and then we found out that she was hospitalized in last November. And so when we dug down deeper, she had not gotten her biologic injection in 5 months. And when we dug down deeper and called the specialty pharmacy, because I was pissed and said, what's going on? Specialty pharmacy had their documentation, their clerk documenting some BS, and said, we called the patient's family 14 times and then we closed it. There's so much of a problem with that. They closed it and she was back in the hospital, hospitalized with an asthma exacerbation. So lots of difficulties with the SP route. I mean, I think it's hard to maneuver. I think a lot of the services that are offered here, especially the tracking, I mean, I think we're going to go home and we're going to talk about who we want to follow up with and try to implement and utilize some of the resources there. Following the PA, we get busy too. We get busy too, and we'll send a PA out. And Liz just told me, which really kind of pissed me off a little while ago, that sometimes those PAs will sit there unresponded, right? We don't get a response and we don't know what's going on. And it can be a couple of weeks, 2-3 weeks, I think, when we realize it's time now we have time to go back and what's going on, and then we start following up on those PAs that are never answered. Sometimes we request a PA and they never get back with us.
Yeah. It just falls flat, or they never receive the fax because it's paper or anything like that. Yeah.
Right.
And that's hard. And then there's other ones that you get automatic approvals, but it's for the wrong benefit. And when you have a newer coordinator, you're still calling to fight, right? And changing the benefits and all that. I mean, it's a very tedious process. And that's really hard on a patient, especially if you haven't set that expectation with the patient that it's gonna take a while. And so I know as a provider that can come back to you sometimes, oh, why did it take 2 months for me to get my drug? A lot of times I say I'm subject to your insurance policy, but I mean, it's true, it does. And especially with COVID over this last year, right? Talk about disparity and things changing. COVID, everyone went to work from home, right? So we're requesting authorizations from payers. They're going to voicemails and we're mailing in things or we're faxing things and it's just sitting there and we're not getting that kind of help. So over the last year, a lot has changed in prior authorization. I think this gold card that Texas is putting in place is really interesting. But I'm curious though with this, right? So you're gonna get past that prior auth part. What's gonna happen after the claim? I'm worried that they're gonna hold claims for medical records. So you're still gonna end up doing something. Any fears on that?
I don't know. Often in the claims process when they're denied, we're denied, they ask for medical records. But yeah, I don't know. Maybe Sandra, you raising your hand? Yeah.
So, yeah.
Yeah, so what Sandra is saying that even now, when you get the prior authorization, they're often requesting medical records, right?
Yeah. So you've done all the pre-work, the pre-service review, you've submitted your auth, you got an approval, you're ready to go. But then after the claim, you just get this medical necessity, and then you have to send records, they review. Sometimes that pushes your claim out 45 days.
So yes, it'll push it out 60 days because 30 days for us to get the letter that they're requiring us to send medical records. So our staff has already identified insurances that will require that. So they're already proactively trying to upload them with the claim. So.
Wow.
I have a question for the audience or for you.
Sure.
Also, Liz, so obviously I already mentioned that I was pretty engaged in this process for many reasons, and I've had lots of colleagues that have approached me that are doing only SP because they've had bad experiences in the past with denials. And you know, they asked me, can you advise me? Do you know where I can get help on how to convert my practice back into a buy and bill? And only 2 people raised their hand a little while ago about their prescriber, whoever that is. And I'm curious, you know, I'm a firm believer that for the process to really work, you need the prescriber, the physician, or the extender, or the non-physician practitioner really on board and overseeing that. And you know, if only 2 of y'all raised your hand, I'm curious, you know, on any ideas and like how are you gonna? I believe the process works if your prescriber is engaged. And I think your prescriber is more engaged in the buy and bill process than in the SP process. And so I'm just curious, what tips do you have to get the provider engaged?
I've got a lot of those. So I've talked about this a few times, I always have that provider cheat sheet, right, that goes through the diagnosis or indication for that medication and what I need to see in the note. And I give it to my physicians and I say, hey, so that I can do my end of it, I need to see where you've talked about this biologic, where you've, you know, clinical indications why, whether that's labs, pulmonary function tests, whatever it is. And then I want to see at the end in your plan, patient is going to start this. And then when they come back, if it's a month later, 3 months later, whatever your preferences are, I want to see that you've assessed how it's going for them, even if it's not going well. Just tell me, is it working, is it not working? And if it's not working, what are you going to do? Give it 6 more months, whatever that is. And then in your plan, I want to see that as well again. Okay, going to give this a try for 6 months. If not, we'll change biologic. So that if 6 months roll around, I'm changing, I've got historical information on what you were planning to do with that patient. And I know it changes. The other thing that I ask providers to do is to understand the time commitment and to dedicate that time or allow that staff member who's handling the biologic or specialty medication time to do that. Again, I know we're all short-staffed. I know our clinics are overworked, but the value of being able to allow them to sit down, focus, and do that, I know they can't stay on hold all day, but carve out Friday mornings for admin time, something to allow them to get organized, to track that inventory, to follow up on PAs, to call patients that haven't come in. It's a huge, huge value. And then looking at the copay assistance side of it, right? Being able to spend time making sure copay cards are processed, or if there's grants or funding, they're able to look and see if it's open for their patients. That's a huge, huge deal to allow providers to allow them that time.
Yeah, and I think those are good ideas. We have a meeting about once a month on a Friday morning. It lasts probably 3 hours. We're also continuously talking. I mean, I have to be transparent. My office is about 5 feet away from Liz's office, so I have a pretty open door policy with her. But I do think that engaging that prescriber is critical for the process. And you know, I've been trying to think of ways on how to engage the provider. In our office, our other providers, they're really not that excited. They just write, and we're taking care of it on the back end. But in other offices, you know, I'm trying to think of ways to get, you know, I think one way is to tell them they're losing money, right? That'll get a provider's attention, right? Everybody say yes, right? It's not necessarily the best way, but once you get their attention, and they have to understand, I believe, the significance of the whole process and that their involvement in it will make it successful. Without their involvement, there's no, I think you have less chance of being successful. I mean, I know it sounds like, well, again, only 2 people raised their hand and everyone is here, and I suspect many of you are successful. But the practices that I've seen where this has not worked well are the practices where the prescriber is not engaged.
So I'm going to assume in your practice, and correct me if I'm wrong, that communication obviously is such high value that if something's not going well, if something's being held up, you like to know about it. So you have that open communication with Liz, and she's able to come and say, hey, I don't know what's going on with this, I'm working on it, and that's a huge value. There's a lot of providers and in facilities where, here's the order, get it done, and the next thing you hear is, why isn't this done? Why isn't it approved? And there's not that give and take. So I would assume you're pretty lucky to have that.
So I get a memo on my desk I'm not really much of an I don't like to use my laptop, but I have to be transparent here. Liz knows I'm digitally, and I'm really, really handicapped in that area. But you know, Liz will 3, 4, 5 times a week, I'll see something on my desk, it's kind of a memo. Call this patient, did this, did that, no answer, you know, and then I'll write down what the next steps will be. We keep a record of all these transactions, so once a month we go through them and see what the outcome was. And the ones that escalate to my desk, the vast majority of them are back in the program. Or we've stopped it because it wasn't working or whatever the other reason was. So again, it's scheduled, like you said, getting that provider, asking them for time. I don't know what the relationship many of y'all have with your prescribers or your doctors or your non-physician practitioners, but you got to have that relationship with them if this is going to be successful. And you can force it. Just mention the word money. You can force it.
So if an advocate, one of the things that we talk about or we've given talks on before is how to speak to your executives or to your physicians about creating a program that gives them the time to focus on that. You know, finances is obviously a big deal. For patients, you guys track data and metrics on compliance and things like that. Any tips or advice on really important points with a patient to kind of bring and say, hey, we're missing this, or whatever that may be, to maybe kind of advocate for that in the practice?
Yeah, from the prescriber standpoint, I think patients are going to be much more compliant. I'm bypassing the PA stuff. I'm talking just about the patient stuff.
Perfect.
I think patients are going to be much more compliant if we have them play a part in the decision making. It can take a lot of time, but we still do that. I think that's critical. I think asking for their commitment up front, like this is going to be an injection every 2 weeks or once a month or every 8 weeks, whatever. And you need we need your commitment to agree to do that for at least 6 months. I think information up front is always helpful. It doesn't always work, but it's always helpful. And then the ones on the back end, it's the communication back and forth, and even calling the patient on a weekend, you know, whatever it takes.
Yeah, that's great. I know we have, in the practice I've been in and working with these physicians, that setting that patient expectation and providing that patient education. I've done 2 webinars for the Healthcare Advocate Summit talking about patient education and the value of it and having that time, allowing your biologics coordinator to go in and explain copay assistance and all that. I think that's such a value to your program. So before we run out of time, I want to say thank you very much. I learn a lot from you and from your staff. You guys communicate with me really well, being on the outside, but I appreciate you coming and sharing the kind of provider side. This was a fun little chat.
Thank you, and thanks everyone for listening and paying attention. And again, I need to acknowledge the fact that this is a pretty phenomenal conference, and it's very professionally done. You did a great job. You and your team did a great job. Thank you.
Thank you. Any questions for Dr. Diaz and I? Yes. We're getting you a microphone so that we can hear you. Sorry.
There's a mic.
We'll use the microphone.
Hey, Dr. Diaz, how are you?
Good.
So I'm Melissa Marino. I know you from San Antonio. I just wanted to ask you, I'm really intrigued about the way you have these meetings set up with Liz and your staff monthly and going over cases. Is there a way that you prioritize the cases that you want to go over in any certain manner? I just think that's great.
Yeah, you know, our meetings are clinical and business, and so we have a set of things that we like to talk about. I like to know, because we have several providers in our practice, I like to know how many new starts did we have in the last month, what were they for, what drugs were they for, how many prior authorization denials did we get, and I can tell you that I don't recall getting a prior authorization denial from that in months, if not longer. I like to find out, so I did new starts, prior authorization. We always, the non-compliant ones, they're always kind of on the radar. We don't wait monthly to talk about those. Any discontinued ones, we review those, discontinued, why they discontinued. Some patients moved, changed insurance. We really don't talk about the finances. I mean, that kind of takes care of itself. I always ask to be told when we get a denial for payment where everything has been exhausted and we're unable to track that. And that's when I start throwing things against the wall. But that rarely ever happens. And those are the top things. And just a rundown. We're looking at processes also. We actually have hired, not hired, we have a couple of consulting groups that help us. And so we're right now working on collaborative agreements with some of the local urgent care clinics to streamline the process of referrals, being amendable to seeing their referrals within 48 hours, communicating back quickly, and providing education to their staff on allergic emergencies and things. So we're always, I'm kind of an entrepreneur too, and I like the challenge of business, and I think it also serves patients, which is really our first priority. And so we talk about these kind of, like the last time we met, it was like, give me a list of the top 5 urgent care clinics, who their CEOs are and their CFOs and their contact information, and that was put on my desk a few weeks later. And now we're talking about the marketing pitch, the slide pitch that we're going to do before we approach them. So those are the kind of stuff we talk about in our biologics meetings.
Thank you for sharing. All right, well, we will be, oh, you have a question? Do we have a microphone over there? It'll be the last one. It'll be the last question.
Well, let's keep going.
Hi, good afternoon. Jennifer Vargas. I'm just curious if you have any ideas on how to engage physicians who, I work for a very large health system, so they work for the health system and not themselves. So money isn't really a motivator for them because they're not getting paid.
So my son is on the faculty at UCSD, and he's in one of these large systems. And he's actually one of the medical directors now, one of these large clinic areas. And he's very much involved in this. And he asks for the support of the administrators, because they really run the show in these systems, right? And so you get the administrators to delegate someone, and you compensate them either financially or time or something to kind of take the leadership of this project. And from our conversations, that kind of stuff seems to work, because as a medical director, he helps in delegating other physicians in the clinic to take over other projects, and it seems to work, especially if you acknowledge them and compensate them. But you're right, it's a revolving door too in some of these systems with even the physicians, right, and the providers. But I think you got to, unfortunately, go through the administrator level and ask them to delegate somebody to champion this. And I think that could work. In a large system, there'll be somebody that's interested. Usually the allergist, by the way. But if you're talking oncology, I don't know.
All right. Well, everyone, we appreciate it. We've got another speaker coming up behind us. Thank you so much for your time. Thank you again, Dr. Diaz.
Thank you. That was fun.
I always enjoy chatting.